me to share.
Hello, everyone. Happy Wednesday. Welcome to another Wednesday VMR. Sharmin here. I am incredibly lucky today to be joined by the one and only Ibrahim, who I'm lucky enough to present, to not present, see, 20% capacity right here, to co-discuss. Big shout out to Nicola and Glenn for subscribing and being teaching points, and I'm so excited Mark is presenting. How are you doing, Ibrahim?
Very, very well. Like, glad to hear that you're doing well as well. I think, Charmaine like teaches us a lot of problem solving on the screen, but there's a lot that goes actually behind the screen. There's just so much empathy, so much resilience that goes beyond the space that everyone sees on YouTube and on live VMRs. So it's great to join you today, Charmaine.
Oh, you're gonna make me cry, and I'm always on the verge of crying these days, so I appreciate you, friend. Mark, welcome, friend.
Hey guys. I'm so lucky to present to you guys today and learn from you all. I just want to preface this with there's like a working diagnosis for this patient. And honestly, the main reason I'm presenting to you guys is I just like want to learn from you guys and hear your guys' insights on this like tricky case and to hang out with
Uh,
you guys as
uh,
always.
that's that's the best. It's about the journey anyhow. So that sounds wonderful. Yeah, if we can get the board up, then we'll get started.
All
So
right.
Marco, whenever you're ready.
Oh, cool. Awesome. All right. So I just got off a week of service. So this is a patient I saw in service. I'm going to edit some of the social history just to correct the patient's identity. But essentially, we have a 30-year-old male who's presenting with 3 months of progressive low back pain and two days of pleuritic chest pain. That's the first aliquot.
Okay, so thank you so much, Mark, for the first autoplot. Honestly, so when I heard this chief complaint, I think of it of three different buckets. The first one is the fact that this patient is a 30-year-old male. And typically because we have a young patient, this is atypical, I guess, especially with the presentation of back pain. And so I'm assuming just based off how this case is starting that this is probably an atypical disease that we're seeing. So this is when it comes to young age. The second thing is the progressiveness of the low back pain. So I'd be much more vigilant if this was a patient who came in and they had acute back pain that had started all of a sudden, possibly due to trauma or possibly due to an underlying disease that they already have. But the fact that they have had this progressive back pain for the past 3 months makes me think that there is an indolent process that has been cooking underneath the surface that will probably take time for us to diagnose. And then the last thing that we've heard about this chief complaint from this patient is that they've had 2 days of pleuritic chest pain, which I'm going to assume is what the patient ended up, is why the patient ended up presenting to the ED to begin with. When you think about such a presentation, just because I'm honestly currently on my ED rotation, sometimes when we hear that a patient comes in and they come in with a chief complaint that contains symptoms like these that may not be interrelated, it might be better to actually take every single entity on its own and dissect it and then try to find something that may actually interlap between both presentations. Why am I saying this? I'm saying this because sometimes patients can present with two different problems at one single time, either due to access issues where they're not able to reach the hospital at all times, so they come in at once and they tell you everything that they have, or due to something that has been indolent, like this patient, where they have this back pain on the background, but now seem to have something more severe, like the pleuritic chest pain, which made them come to the ED. When I try to dissect one of these three problems, I'd probably choose the pleuritic chest pain, just because it seems to have a more acute nature in presentation. And typically the thing that you worry about the most, at least from my experience, when someone comes in with risk factors for coagulation is you want to think about PE as a cause for pleuritic chest pain. But that does not mean that only PE can result in pleuritic chest pain. Anything that can result in inflammation of the pleura itself can eventually result in pleuritic chest pain. And that can include PE, but it can also include pneumonia. It can also include malignancies that transfer to the pleura or to the lungs and can irritate the lung margins. Otherwise, there's also other causes that can manifest in the chest, but I don't think we have the space or the time to go into all of these at once. So Charmin, would love to hear your thoughts if you have anything to add.
Ah, you're so brilliant, Ibrahim. I just like love the reasoning, the thought process, and I loved every second of that. And yeah, I totally agree. I think like, if you're seeing this patient, you really want to better understand that pleuritic chest pain and like pulmonary embolism is for sure one of the diagnoses you don't want to miss. Um, and I think like as you mentioned, like the question is like, are these two complaints related to each other? Are they one of the same or the same process affecting the both? Like a couple of things that I would like kind of worried about, like kind of like aortic dissection type picture, if there's any like kind of like vasculature or cartilage abnormality. As you said, like 30 years is like quite young. So kind of like having that a little bit more in my forefront, that I'm like, if in terms of like our no misdiagnosis in addition to pulmonary embolism. And the last one that sometimes like these two get lumped in together, or like in the patient's presentation, is often thinking about like any like spondyloarthropathies that could kind of have a progressive background, the pleuritic nature of it. And like someone younger, I think like kind of if you start getting a little bit of autoimmune flavor that like affect the pleura as well as the spine, that is something else to make note of. But I think like for me, as always, like common things are being is like common. So like start working up the pleuritic chest pain, thinking about, is there anything going on in the lung, any like pericardial issues, like pericarditis being very common. And then I'm not forgetting about our no misdiagnoses. And then I think the context also would be really helpful about like, is there any other like um, inflammation symptoms or like any prior illnesses that would help us like make a little bit more progress on this case. But so far, this is very intriguing, Mark, and I don't expect anything less from Dr. Heslin. All right, back to you.
I really wish I got to work with you guys. I'm really trying to make strides in that CP Solvers hospital, honestly. This is awesome. Okay, so that was awesome. So I'll just tell you how the case was framed to me, because commonly in hospital medicine we'll get a page from the from the emergency room about like either the reason for admission or the diagnosis. So the page was for a pain medicine consult and for pain control. I'll say that just for context, this was this patient's seventh admission in the last 3 months for back pain, or seventh, I should say, ED presentation, only one prior admission for the back pain. So essentially, this back pain started 3 months ago. I'll say, interestingly, right before the back pain started, the patient was in Kentucky. So that's like in the, for you guys that are not familiar with the US geography, that's kind of in the central eastern part of the US. So the patient resides in the Bay Area in California, but took a trip to Kentucky for work. He was in Kentucky for about 2 months. And then he developed symptoms of what he said of prostatitis. He had some perineal pain, some dysuria, and he said he had a clinical diagnosis of prostatitis. He wasn't sure if cultures grew anything. He was on antibiotics for about 5 weeks for prostatitis. He wasn't sure which antibiotics those were. He said that those symptoms of what he called prostatitis resolved, and then shortly after, he said almost a day or maybe a very short time after, he developed this back pain. So yeah, this back pain has been going on for 3 months. He said the back pain is just really bad at night. He's just having a lot of trouble sleeping. It's also bad in the morning as well. He's not able to really tell me about like morning stiffness, but he did tell me that the pain is a little relieved when he stands up and walks around for a while, but then when he lays down at night, it's just really, really bad. And like I mentioned, he's went to the ED 7 times for this back pain, really without an answer. And it's just been so progressive over the last 3 months. He denies any pain in really any other joints, really just in the back. He denies any like radicular symptoms, no shooting pain down the legs or numbness or tingling, saddle anesthesia, bowel or bladder incontinence. It's really just localized to that lower back. Um, and as far as the chest pain, like I mentioned, and also for the back pain, he's never had back pain like this before. This is the first time he's really had any issues with his back and no preceding trauma or anything like that. For the chest pain, like I said, it's worse on inspiration. Never had chest pain like this before. And he also states that it's better when lying down and is worse when sitting up. So that's kind of his HPI. Past medical history, has a history of diabetes that was diagnosed about 5 years prior to admission. He is on insulin for that, and his A1C is 8.5. No other past medical history for him. Medications, like I mentioned, he is on insulin and is also on metformin as well, but no other medications, no over-the-counter medications. For family history, he denied any really, he said he had a family history of arthritis. And when I asked if this is like osteoarthritis, like wear and tear, or more like rheumatological, like RA, he wasn't sure. He just said that he had a family history of arthritis. He also said that his dad actively has prostate cancer and is undergoing treatment, is actually doing quite well. But unfortunately, his mom passed away recently from lung cancer. No history of other rheumatological diseases at all. And for his social history, so he lives in the Bay Area. I mentioned that trip to Kentucky. He is from Peru. So he's from Peru, and then he moved to Colombia about 6 years. Or he moved to Colombia, and then he stayed there for a few years, and then he moved to the U.S. about 3 years prior to admission. He works as a truck driver. He is in a monogamous relationship with his partner, and he lives with his partner and a few kids. And his dog recently died, unfortunately, but no other animal exposure. And I'll leave that for the end of this aliquot.
Ibrahim, would you like me to go first, or do you want to
Oh,
take a
please,
first
please
one?
help me out here.
Okay, how about I do like a little bit of the HBI, and then I really would just want to hear your thoughts on it. First of all, just gotta give Mark his flowers. It's just like you take like such impeccable history, and your patients are so lucky to have you as their physicians. Like every sentence is like has been with such care, and I'm so sorry about his dog. That is like really, really sad. Um, so I think like the additional information. One thing, like maybe I'll just like think out loud about the prostatitis kind of diagnosis a little bit. In general, like one good learning point about like patients who present with like acute prostatitis is that they're actually quite sick. So these are people who like similarly like with pyelo oftentimes like come in with like very surgy response. So what if what we're hearing like doesn't mimic that is like thinking about more like chronic prostatitis. One the reason that this was intriguing to me that he got antibiotics, like oftentimes for prostatitis in the US, we either give Bactrim or like a ciprofloxacin, and like Cipra has been associated with like some aortic and vessels issues like aortitis. So that is like something that made me worry that if he got Cipro and because of the back pain that is worsening, the pleuritic chest pain, like thinking about like to makes me want to even rule out any aortic pathology. But whether like that is actually the prostatitis diagnosis, it's the other reason why I'm just like curious about that is that, if there's like the timeline kind of matches, oftentimes like if you have any like bacterial translocation that can cause seeding, like osteomyelitis, those things tend to have like worsening back pains, and like some like pelvic pain pathology as well that kind of goes with the chronic prostatitis and like osteo. So that's like another way that potentially point us towards like thinking a little bit more about the inflammation in that regards. I think like the pain that is like, improves with walks around and like worse when with stuff that has like some like autoimmune flavor to it. Um and um and I think like focusing on the family history, I'm trying to dissect that a little bit, and if there's any family history, if that was like as always, like Parks is like right on the point. So it definitely got gives like a little bit of a more of an like auto-inflammatory processes. However, again, like I think that remains to be seen if this patient is like truly inflamed or not. I think as of now, before passing the mic to Ibrahim to hear what he thinks about like kind of the most background information, is that I think your exam, his vital signs and the labs will really help guide you to kind of frame this patient a little bit better. And I think the biggest thing I'd be looking for is like kind of signs of like inflammation. Um, and I think like with that type of a history, like progressive back pain, the extent of it, you just have to get the spinal imaging just to get a better understanding of where his pathology lies. I'm gonna stop there, and then I want to hear what you think, Ibrahim.
Ibrahim.
Poetry, Sharminia, I don't think. Oh, sorry, Mark, did I cut you off?
Sorry, can I just mention one thing? Because I think I meant to mention this in the HPI. Maybe Ibrahim, you can talk about this in addition to the things that you want to chat about. But the patient, in terms of like, Charmaine, you were talking about inflammation, and the patient denied any fevers, but the patient did actually report about a 40-pound weight loss over this time. He denied any obvious reason for the weight loss. He said he's eating 3 square meals a day, what he usually eats, and he's not had any issues with swallowing or at all. He did say that maybe also over the last 3 months he's been having some alternating constipation and diarrhea. No like bright red blood or hematochezia or anything like that. He's not really able to characterize that like anymore, and it's kind of like unclear if it's like true diarrhea or not. And then he also does report some occasional night sweats as well. I thought that was an important part. I totally forgot to mention that, but
Thanks, Mark. So honestly, I feel like every time you say something, it makes the case more complicated, but which makes me even more excited to hear this patient's final diagnosis. But Charmaine, honestly, poetry. I don't think I have much to add to it. I feel like if there's the three more important, I feel, main points that we've learned from hearing the HPI is one, the history of prostatitis and the fact that this only started after they had that infection. The history of travel to Kentucky, which I'm not sure what to make of as someone from outside the US. And the third thing is the history, the family history. And I guess now that Mark has mentioned the weight loss, that seems to be atypical, I guess, for something that is indolent. But if there's something that I could weigh in, I feel like I also agree with Charmaine with all of what she said. Um, the fact that this has been an indolent process that has been going on for 3 months, the fact that there is family history of arthritis really makes me think of spondyloarthritis. And you know that the fact that all of this seemed to have started after the patient had their prostatitis, but we don't know if they may have had the back pain for a period longer than that before the prostatitis had started, but now that it's worsened with the prostatitis, it's only that they're noticing it now. Um, and I say this because I know that certain infections can lead to worsening of symptoms. So when you think, for example, of genitourinary infections, um, such as, for example, chlamydia infections, those can result in reactive arthritis. And they typically worsen symptoms for patients who have predisposition for certain bone conditions. So, for example, if someone has HLA-B27, if it runs in their family and they're predisposed to spondyloarthritis and they end up actually having a chlamydia infection, they end up having worse symptoms of reactive arthritis than someone else who doesn't have a predisposition for reactive arthritis. So that was just a thought that I had in mind. Um, I feel like it would help a lot. So apart from also knowing the antibiotics that this patient had been on, I feel it would help also to know if there was an organism that was isolated to be causative of their prostatitis. Just because, again, with the story of chlamydia and how it can cause reactive arthritis, I feel like it would go a long way if we can actually know or learn about a specific organism. And then when it comes to the history of travel to Kentucky, just like based off standardized testing, and the setting that I've done for that, I know that associate the Midwest. I'm not sure if Kentucky is in the Midwest, but like the eastern part of the US with like certain fungal infections. And the fact that this patient had pleuritis, um, in addition to all of their background symptoms, makes me also worried about that. So I do wonder if at some point in the case we're gonna hear about bronchoalveolar lavage. But would love to hear more from your casework. So the floor is yours.
Amazing, guys. This is awesome. So let me give you guys the exam and the basic labs. Um, so, so the exam. So the patient was afebrile. The blood pressure was 115 over 77. The heart rate was about 110. I will say I looked at all of the patients like last 7 like ED presentations and the vital signs, and the patient was always tachycardic every single admission, just for context. The respiratory rate was normal. The patient was saturating 99% on room air. The patient's BMI was 17. So just with that weight loss that they had. And on general exam, the patient was very cachectic and writhing in bed in so much pain, almost in the fetal position on the side, just in so much pain. And the first thing the patient said to me, and I think it's just important to mention, is that he's like, he was Spanish speaking, and he told me, he's like, please, doc, I just need an answer. Like, I'm very depressed about this pain, and I can't take care of my family. And what he told me, which was really sad and really angered me inside, is that I've been called like a pain seeker and on many ED visits previously, and no one's really taking my pain seriously, and everyone thinks that I just want opioids, and yeah, so. On HENT exam, nothing really notable on HENT exam. Cardiovascular exam, the patient was tachycardic, but it was regular, and I didn't appreciate any murmurs. On pulm exam, clear to auscultation bilaterally. Nothing notable on abdominal exam. So neurologically, patient was, AOA times 3, cranial nerves were intact. Strength was, he was very strong in the upper and lower extremities. Reflexes were normal. His sensation to light touch was also normal. I couldn't check his gait because, he just was in so much pain. And then musculoskeletal exam, he had extreme point tenderness in the lower back, the very lower back, like kind of around the sacrum, on the spine, and then also right, like kind of adjacent to the spine as well on both sides. And he wasn't able to like move his back at all. Like range of motion, it was too painful for him. I'll go to basic labs next. So for basic labs, the patient had a white blood cell count of 9.7. The patient's white blood cell count was 9.2 about 2 months prior to admission. The differential was completely normal. The hemoglobin was 15.3. The platelet count was 419. The MCV was 89. And for the chemistries, for the basic or the complete metabolic panel, the sodium was 135. The potassium was 4.5. The chloride was 102. The bicarb was 21. The creatinine was 0.35. The BUN was 21. The glucose was elevated at 300. The anion gap was 12. The magnesium and phosphorus were normal. And then for the coagulation studies were also within normal limits. The patient had an ESR and CRP. The ESR was 2, and the CRP was less than 0.03, so essentially undetectable. The patient had an EKG that showed diffuse ST segment elevations in the precordial leads. And the patient also had a troponin that was negative and a BNP that was negative. Patient also had a chest X-ray, which was unremarkable. I'll leave it to you guys. You guys let me know if you want, I'll say there's imaging of the spine, if you guys want the spinal imaging now or in the next alpha.
What do you think, Ibrahim?
Honestly, yes. So I feel like there's a lot to dissect here.
Yeah,
But I'll
I
start with the
agree.
exam. Yeah, I'll start with the exam, honestly. I feel like the fact that this patient has the most remarkable thing from the exam is that one, the patient is in pain, and two is the extreme point tenderness. And I feel like the extreme point tenderness maybe tells us more that this could be something that has resulted in a stress fracture. So I'm gonna assume at this point that this is something that is probably infiltrative and has increased this patient's propensity to actually getting a fracture in the back. This is what I make of the physical exam that they have. When it comes to the labs itself, I'm not sure if there's something to make of. I guess what really threw me off is that this patient's CRP and ESR are both undetectable, especially given the fact that they had this very heavy, I guess, history or HPI that may have clued us towards an inflammatory cause, considering all of the weight loss that they've had, considering all of the night sweats that they've been having. So I do wonder how you can have a normal inflammatory studies with the context of such a patient. But hoping to learn more from you. And then one last thing, I guess, which I feel is also remarkable in this patient's workup, is the diffuse ST segment elevations. And if it tells us something at this point, I'm gonna put my money on pericarditis. Um, so I do wonder if we're looking at a multisystemic inflammatory process here, but Charmaine would love to hear your thoughts as well.
Yeah, I totally agree. A tricky case. um, and yeah, I think yeah, I share your concerns about like kind of the point tenderness and being like kind of an infiltrative process. And I think I'm sure an MRI of spine of some sort of imaging is coming our way. In terms of like the ST segment elevations, I yeah, my first thought was also pericarditis. I think like in this, as y'all know me, I always like live in the fear of missing a diagnosis. And I think like especially with someone that we don't have that much background information, if there's any like uh, I would just like get the troponins, like make sure the ECGs, just make sure that you're not dealing with a more of like an like an ACS type of pictures. Most likely, no, given the history and everything is like very concerning for pericarditis. In terms of like the inflammatory markers, I honestly, I think I'm just going to put them aside for now because I feel like the clinical concern for something inflammatory is quite high. And I think that degree of weight loss, it's really helpful to help frame the case is that whatever is happening has to explain the degree of weight loss this man is having. So it doesn't sound like it's a PO intake issue. So it's either like kind of the inflammation and the underlying malignancy, or the other thing is like to think about is like a GI issues. Like is does he have any malabsorptive process going on? Is like that diarrhea is actually a lot more significant that bears in, that comes to mind. And so I think like to kind of like think a little bit more about like kind of like the pericarditis part of it as well is that I think like kind of like my first thought like thinking about like pericarditis is oftentimes actually turns out to be idiopathic post viral etiologies. But the things with the infections that you want to make sure like granulomatous infections like TB, histo, those things can definitely cause pericarditis. And there is like people tend to be like more acutely sick when they have like a staph aureus pericarditis. In terms of like the cancers, oftentimes um like a more it's like more local issues like mesotheliomas and stuff that can do it. And then I think like you have the inflammatory diseases that can do it. And I think between like the autoimmune diseases like, lupus, RA, and then seronegatives like IgG4 disease, like histiocytosis, Still's disease, those are like the ones that tend to do it as well. I think in terms of like what I would worry about is that I still think like a kind of a autoimmune disease is possible. With the GI involvement, I worry about like are we dealing with like maybe an IBD or something that can have also a significant amount of weight loss associated with that, as well as like spondylopathies that could be possible. The other thing that I'm worried about is like a granulomatous process that can be infiltrative, that might not lead to like as much like systemic inflammation as more like infiltration. Those are like my thoughts. Before we turn back to Mark, any other additional thoughts, Ibrahim?
No, I found it really inquisitive what you mentioned about the CRP and ESR because I also, a lot of people have been mentioning this in the chat, and I guess, just considering that this patient had such a heavy background of an inflammatory nature progression of disease, I probably wouldn't rule out that yet, just like you suggested, and would probably just keep the ESR and the CRP aside. So thanks for sharing that, Shannon.
Mark, I'm on the edge of my seat.
As was I, as was I. Okay, so I'll just start with the spinal imaging. So we got an MRI of the lumbar spine with, particular attention in the comments to the SI joint. And it showed edema and enhancement within the bilateral sacrum and iliac bones, with edema and enhancement within the posterior soft tissues adjacent to the right greater than left sacroiliac joints. No joint effusion. And then mild degenerative changes to the lumbar spine without high-grade spinal canal or neuroforaminal narrowing at any level. Additional labs, we also, given the mild thrombocytosis and the concern for inflammation, as you guys mentioned, also got a ferritin. The ferritin was elevated at 538. I repeated the ESR and CRP, and essentially my thoughts were the combination of your guys' exact thoughts. I was like, this person definitely has inflammation going on. I feel like now, as I just like gain more experience, anytime like I have a lab that I think will be positive that turns out to be negative and it's pretty cheap, I just wind up repeating it just to make sure it's not a lab error. And again, the ESR was 2 and the CRP was less than 0.2 the following day, so it continued to be negative. We got a transthoracic echocardiogram given the concerns for pericarditis. And Sharmin, the repeat trope was also negative, and then repeat EKGs that were trended for the first day, all the same, diffuse ST segment elevations. The transthoracic echocardiogram showed a very small pericardial effusion with a normal EF and no valvular disease at all. So we diagnosed the patient clinically with acute pericarditis, and I started the patient on NSAIDs and colchicine for pericarditis. And I'll say for that part of the patient's presentation, his chest pain did improve with colchicine and NSAIDs, the chest pain specifically. We also got a pan CT scan, given the significant weight loss and all the reasons that you guys mentioned. Let me read that to you guys. So the CT, so this is a CTPE as well. So there essentially it was rather normal. I'll just read the impression, then I'll give a little bit in the body, and I'll just say it's always important to read the body. At least I feel like where I've practiced, sometimes things can be just in the body of the read, but not in the impression. Then you're like, oh wow, I thought that was pretty significant. But there was no acute or chronic PE. And then I looked at the body of the scan. The only thing that was noted is that there was a focal calcified granuloma in the left upper lobe, and minimal background bronchial wall thickening, and a calcified left upper lobe lymph node as well, but nothing in the parenchyma at all. And then the CT abdomen and pelvis. CT abdomen pelvis showed multiple thin linear and wedge-shaped areas of cortical hypoattenuation through the bilateral kidneys. These findings are nonspecific, but could represent bilateral renal infarcts or pyelonephritis in the right clinical setting. But that was really the only thing present in the abdomen, no lymphadenopathy. I'll say the patient currently had no urinary symptoms at all and had a urinalysis that was completely normal. And I think I'll leave it there.
All right. Ibrahim, do you want to just dance together? Should we just talk together about what is jumping out to you before I jump in?
Yeah, I guess honestly, there's a lot of interesting stuff here happening all at once. I guess the most remarkable thing from this article is the calcified granuloma in their lung. Uh, because I'm not sure what to make of the linear findings that were found on their kidneys. But just like the fact that this patient had a calcified pulmonary nodule makes me think of something like histoplasmosis. But then once again, when I think about histoplasmosis, typically I think about it as a pulmonary disease, and you only like when you see disseminated histoplasmosis, it's typically in a patient who's immunodeficient, who like has AIDS. Um, so I'm not sure what to make of histoplasmosis in the context that the fact that this patient also has a disseminated disease. But I could also think about TB at this point, especially with the fact that they've immigrated from Colombia recently. Um, but would love to hear your thoughts as well.
Yeah. Yeah, it is quite fascinating, right? Because sacroiliitis, we have pericarditis, we have GI symptoms, um, and like significant amount of like weight loss. So I think like you're thinking about like, oh, I'm worried about like a systemic inflammatory syndrome is spot on. And the question is like, what relates all of those things together? And I don't know if I like have a really good answer for that. I think just like oftentimes with like other like inflammatory syndromes, like I don't often see like that much weight loss unless it involves like the GI tract of some sort. So I think like sending out the HLA B27 is a good call because I think they're also at risk of pericarditis, although I don't quite know if that alone explains the degree of inflammation. So I feel like IBD plus a spondyloarthropathy still is something that I'm considering here, and I wonder like if this is someone, especially if we get a more history of like more significant GI symptoms, but with like a colonoscopy be informative. And then I think like your point about like kind of this granulomatous infection is like very well put. The one thing I forgot to mention earlier is that like, I think like HIV is a good thing to get in a patient who's like coming in when you're not sure exactly like the context and also like how immunocompromised they are and what they could be at risk for. And I think like as you mentioned, like his whatever TB can do, his son can do better. I do think like this patient's at risk of TB and disseminated TB is also like a good thought. Can definitely cause pericarditis as it can do anything it wants. And the other thoughts that I had was, the other one that I was like thinking about was kind of like a SLE lupus type thing, but I don't really. In my illness script, it doesn't involve sacroiliitis as much, but people correct me if I'm wrong. So like that makes me like a little less likely. And then oftentimes like lymphomas can present very oddly too. I've never seen like a sacroiliitis as well, but like sometimes if there's like a perineoplastic syndrome that accompanies them that can do it, would be what I would worry about. So if I'm like taking care of this patient, um, I think like granulomatous diseases is one that I would because like sarcoid is a good mimicker as well. So that is like um, would be first on the differential, and the second one would be kind of like a more autoimmune disease, like an IBD essay would be the other one that I would worry about. How does this relate to like the prostatitis, all of these things? I'm not sure, other than as you mentioned, like it may be an infection unmasking an underlying autoimmune process. But I think I would just let that aside and like kind of focus on the pertinent positives of like the pericarditis, the sacroiliitis, and try to frame the patient that way. But yeah, that is kind of where I'm at. Ibrahim, anything to add? Oh, Jeff tells me not sarcoid. Thank you, Jeff. I appreciate that. It's great to have a rheumatologist here.
Like having a free consult. But not much to add. Thanks, Charmaine, for teaching us so much. So Mark, please.
Ooh, sorry. The last thing is that the thin linear and the wedge-shaped areas of the kidneys. Oof. Mark, you're not really making it easier for us. So I think like when I see those, I often think about like if there whether it was a remnant of the urinary infection that this patient had. Like, did it have like a prior pyelo that was and because oftentimes like with chronic prostatitis something has seeded the prostate, so I'm like, oh, is it a remnant of that? But if it's not a prior infection, then you got to invoke kind of like possible like phenomena, like something like endocarditis type picture, which would be a bit odd, but endocarditis can do anything. But yeah, I'm having a hard time putting that together with like no other signs of like thrombotic or embolic events. And like with like a coags that were like completely normal. So I don't know what to do with that yet. It doesn't quite fit the one that like kind of thinking about more like kind of IBD autoimmune phenomena that we were more worried about. So yeah, any thoughts about that, Ibrahim?
Not really. I guess like I couldn't also pinpoint that apart to anything apart from their history of prostatitis. So I do wonder if there's a chronic component that we're seeing here.
Yeah, I mean, oftentimes, like, if that was like a prior infection that led to endocarditis, you can always like invoke kind of reactive arthritis. But again, like with pericarditis would be very rare in that situation. So yeah, I'm not sure. Mark, any other information?
Yes, it is always so cool to see your guys' thought process and be like, oh yeah, I should have thought of that during this time. That it's just really awesome. So yes, I have one last aliquot. I'm a huge splitter in general, especially in cases like this where I am just like you guys, kind of unclear if everything's related, if some things are related. So I'll kind of give you guys the labs and workup by problem in a way. So for the pericarditis, we got a respiratory viral panel that was negative, an ANA that was negative, an SEL70 and a centromere that was negative, an RF that was negative, and a CCP that was negative. For the renal infarcts, the patient had APS, antiphospholipid testing, and I talked to the radiologist, and they were pretty convinced that this was renal infarcts in terms of how it looked on CT scan. But they did say, and then they said based on the location, how symmetric and bilateral it was less likely to be embolic, is what they said. We got APS labs and hypercoagulable labs that was negative. A TTE with bubble was done as well. There was a bubble on the original TTE that was negative. The patient also had ANCA serologies as well, which were negative, the ANCA screen and then the MPO and the PR3. An HIV test was also done, which was non-reactive. And so I forgot to mention the thyroid test for the weight loss was also negative. Had very similar thoughts in terms of the infectious testing. I got urine and serum antigen testings for blasto and histo. Those were both negative. Serum blasto antibodies were negative as well. We also got Coxy. We see Coxy like every day, I feel like at Stanford, and that was negative. Coxy screen was negative. A quantiferin gold was also obtained. That was negative. The patient actually reported that they also had tuberculin skin testing like a week before they came to the hospital with their primary care doctor. That was negative. And then this is one of my favorite parts about hospital medicine is I can just go back to the bedside as many times throughout the day as I want just to gather more information, which is super fun. So especially after we got the MRI back, I just, all of that social history that I gathered was on the original interview, but I just wanted to gather just a little more social history after having the MRI. Especially based on exposure history. And I really just try to get out of like any animals or any farm exposure. And he said no farm exposure, like farm animal exposure. I learned from my brilliant wife, who's an infectious disease doctor. You guys probably know that it's also important to ask, like if you're asking about zoonotic disease in general, it's not only important to ask about like if they interact with farm animals, but if they drive past, farms and farm animals, because a lot of these are spore diseases. So like if you drive past a farm, the spore can actually enter your car and you can inhale it. And the patient did say that, they're a truck driver and they actually did drive past a bunch of farms in Kentucky. So I sent Brucella antibodies as well, which were negative. I'll say right now the Coxiella and Bartonella are pending. So they're not back yet. And then I'll give you guys, we obtained a PET scan as well. And the PET scan was completely normal. Just showed that SI joint, inflammation and the pericardial inflammation as well, but no other FDG avid nodes or masses or really anything like that. And I guess the last thing I'll give you, and you guys let me, I'm reading Andrew's comment in the chat. That's why I'm laughing. I we got the last test I'll give is the HLA-B27, which was negative. And I might have missed something, but you guys let me know if there's any other labs you guys would like as well.
All right, boss, what do you think?
Definitely not a boss, but
You are a boss.
thanks, Sharmin. So honestly, yeah, what an interesting like take, the teaching pearl that Mark had just mentioned that, you don't just ask about if a patient had direct contact, but you also ask if they've been driving through farms. Just makes me think of all the patients I've seen throughout med school whom I should have probably asked about that. But anyways, that being said, the fact that this patient had this disseminated infection and the fact that I feel as the case goes further, it seems that it leads us more towards a zoonotic origin of their infection. Mark had already mentioned a lot of infectious etiologies that could result in such a disseminated picture that came back negative. Um, but I guess what I truly think about, right, at least for the time being, and the fact that this patient had like pulmonary involvement and pericardial involvement is hantavirus. But I do know that hantavirus is more of like rodent urine and feces. So I wouldn't expect that to be transmitted by spores. There's also leptospiriosis, but then I have never seen leptospiriosis in a patient without a hepatic involvement. So that also keeps it at the lower end of my differential. Also, the fact that leptospiriosis, once again, just like hantavirus, I feel like I associated a lot with like urine of like animals, of infected animals. So I wouldn't touch onto that yet. I guess I feel my money right now is probably on the Coxiella, which is still pending, or the Brucella. If I had to choose one of those, um, that may be causing this patient's presentation, I'd probably pick Coxiella just because Coxiella is like more inhaled spores, whereas brucellosis I tend to associate it with like unpasteurized milk intake or meat and undercooked meat. So that's just like a cool that's just like me choosing between two things, but would love to hear your thoughts as well, Charmy.
Yeah, I've like definitely been humbled by Coxiella, like kind of like that culture negative endocarditis. Although like the PET being negative for that makes it a little less likely in my mind, but for sure, I think like Coxiella, Brucella both were like really amazing thoughts, and for the serologies to send. To be honest with you, I have no idea what this is, and I am puzzled still, mostly because like the degree of weight loss and like what we've seen just like doesn't match each other as well. So I'm like, okay, where is that delta? And like person and Mark also like pet people also hate me. So you're not alone in that. I wonder if this is someone that I would consider like evaluating the GI tract. I would probably see if GI is willing to do like an EGD colo to see if there's anything hiding there that can give us an answer. And then I think the other thing you just always have to be cautious with TB is that like is your clinical suspicion low enough that like um that quantiferon and PPD would dissuade you from this being like disseminated TB. So whether like you would actually would want to rule out active TB. And if there's the other thing that I would say, like when I'm not sure, is that is there anything we can go after that would any tissue that can help us like make progress? So if there is the bony involvement with the bone biopsy would be helpful. So those are like kind of the other threads that I would will try to work on to like better understand the problem that I'm trying to solve, because the problem is like pericarditis, significant weight loss, sacroiliitis with like largely negative workup. The other thing is like, are we dealing with like a sneaky malignancy in the setting of a pet that being really normal? And like no lymphadenopathies like makes lymphomas and stuff a little bit less likely. And then the last one that I've been mentioned that like can kind of like present with like kind of some pericarditis and stuff is like IgG4 disease. I don't know IgG4 disease causing sacroiliitis. I don't know if anybody in the chat or other people have that in their in the script. So I think yeah, those are my thoughts. Sorry, they're not very well formed, but those are kind of the threads that I would go after because I still we don't really have an answer for the renal infarcts. And I feel like the other and like kind of stepping back is like, oh, and I love that Mark is also a splitter, not a lumper. And I'm like, what if like yeah, the pericarditis is just not related to whatever it's causing? Like what if that is kind of like a viral idiopathic thing and has nothing to do with the rest of the pathology? So I think those are I would like try to like link different problems together and try to solve this case, sit with it at different angles in real life. The last thing that I had a question on, how is his hemoglobin A1C in terms of like his diabetes?
8.5.
8.5. Okay. So that's the other like kind of thinking about like is he at any risk of like nocardiac or like these type of infection, but it's like doesn't really seem like that type of a clinical presentation for me too. I'm just like thinking out loud and pontificating. I don't have anything more useful to add. But like those are like some of my thoughts. Ibrahim, anything else to add?
I guess, sure. I mean, I'm kind of still puzzled by the fact that, TB remains on the differential. Especially that, you've mentioned that with such like a dense history that may actually clue us towards a very high pretest probability for TB, you wouldn't just rule out that yet. So I was wondering, like, if this patient was like under your care, would you just repeat the quantiferon? Would you like take a biopsy? Like, how would you approach testing for TB here?
Yeah, I think I would talk to Mark's wonderful wife, Yutara, with our IT consultant. But yeah, I think I would like go after if there's a biopsy site because one is like okay, pulmonary TB, but if you're invoking disseminated TB, they might not have any pulmonary findings, so you can always like start with ruling out like active pulmonary disease. And then I think it would be kind of like biopsy of any site that you think might be involved. Like in this case, if there's any like bony involvement, whether that would give you enough of a sample. But yeah, I think. yeah, I think like for me, TB is still on the differential. And I think like Jazz is mentioning endemic mycoses, and I think that is those when you invoke that, absolutely that could possibly be. I just like don't know if it's like fully explains like kind of the pericarditis type picture. So yeah, I don't know. Mark, what did you all think?
That was amazing, guys. Like I said, I don't have a final answer for this case. I'll let you guys know my thoughts. We'll probably have a final answer within the next week, I'm sure. So I'll keep you guys posted. The last thing I forgot to mention is there was I mentioned his like diarrhea and constipation was kind of unclear, and he wasn't really having much diarrhea when I was taking care of him. But I think he had like one episode of diarrhea, and like on admission, I ordered the fecal calprotectin for the reason you guys mentioned too, of an IBD related spondyloarthritis, and it was mildly elevated. Like yesterday it came back to like very mildly elevated. Like I forget what our upper limit of normal is, but it was 75, and it's in like our lab it actually says like borderline for what that's worth. Um, but yeah, I think in a case like this, I was just like splitting everything and then also just to like try to make progress on the diagnosis because things weren't just matching up for me. I think it was a classic case of like Hickham's Dickham's Occam's razor, right? Like what things are related and when things are true, true, and unrelated. And I was just trying to cross off different diagnoses to try to, narrow things down exactly like you guys were. Honestly, before the blastomycosis serologies came back, I thought it was a pretty decent case for blasto. And the reason I mentioned that too is that the prostatitis history was a little unclear, but one of the most common non-bacterial infectious causes of prostatitis is blasto. Blasto actually loves to go to the prostate, TB as well. And I do agree with Jazz's point. Like I feel like I'm just more and more skeptical as I gain more experience about just like the test characteristics of different tests. But I will say that the test characteristics for disseminated fungal infections are for disseminated fungal infections, which we would be invoking here, are pretty good when you combine all of them together. The urine and serum antigen. We also have a dimorphic fungi PCR here at Stanford too, which increases the sensitivity when you combine all of those. So I felt pretty good with ruling out histo, blasto, and cocci for now. So like we ruled out a lot of the infectious cause. I also thought it was a decent case for brucella too, before the brucella came back because some of that may be farm animal exposure. Um, I think for me, I almost started to ignore as the days went on the pericarditis because it was so acute and then it kind of just went away with colchicine and then like the most common just being viral or idiopathic. So I'm like, it's on the list. We'll see if it gets incorporated in the end, but like I'm just going to chalk it up as viral or idiopathic for now because we usually just don't culture anything. And most patients with like fungal pericarditis or TB pericarditis are really, really sick, like Charmaine mentioned. So it seemed a lot less likely. I think I've sent this on multiple VMRs, but it's like always TB. And I think we just need to exonerate TB in this case. So I consulted IR, which they couldn't find a great biopsy target based on the MRI. And that's actually one of the main reasons we got the PET scan to see if there was any other biopsy target. I think the team is going to talk to IR again today to see if based on the PET, even though nothing else lit up, like maybe it helped them see a spot on the SI joint, which they can biopsy because really the infectious causes of sacroiliitis, if not like bacterial, which this is obviously not, it's not going to go on for 3 months, is really TB, endemic mycoses, and zoonotic organisms. So I think they really need, and like as mentioned, like the quantiferin gold just really doesn't do too much for disseminated TB. So really tissue is the issue. But I think I still think, and I'm very curious of what Jeffrey thinks as well, our expert rheumatologist, like, could this be, like you guys mentioned too, like with the weight loss and the GI symptoms, like a IBD associated spondyloarthropathy? I was actually texting with the attending today. I'm like, I think given the mildly elevated calprotectin, like getting a colonoscopy, like you mentioned, Charmaine, is probably a good idea because that I think would help like make us feel better about the weight loss. Um, but I also did learn that, 20% of patients with seronegative spondyloarthropathies will also have a negative HLA-B27. So it doesn't rule it out. And I saw that also like 40% of patients with these diseases too will have a negative ESR and CRP. So um, I think right now for me, I'm like TB versus IBD associated spondyloarthropathy and uh, ankylosing spondylitis. The renal infarcts, it's a puzzle to me. I don't know with the workup we did, it's just again like it's hard to I feel like renal infarcts to say in such a young patient that it's true and unrelated to systemic disease, but it's like it just doesn't fit well. And I actually talked to Kirtan about this case too, a K consult, and we were talking about like vasculitides that can present as like sacroiliitis. It's just they're so uncommon, like Brichette's presenting like this, or some other like variable vessel vasculitis, and the ANCA serologies were negative. But yeah, really fun case. Yeah, I just talked a lot, but it was a fun case to walk through. And thank you so much for your guys' expert opinions.
That was brilliant, Mark. I love how you framed it, your like thinking process. You're just such an incredible diagnostician and a physician and a human. So deeply appreciate you. Yeah, I totally agree with you. I'm like, yeah, I think like ruling out TB, and I would kind of personally get the colo. I don't know if Jeffrey is in a place that he can unmute and help with his like expert opinion, but that's what I'm just like, I think in terms of like a weight loss part, like I think the other clue would be if you had any like nutritional deficiencies or anything else on labs that will clue you in, like if you has like any malabsorptive process. But I think to complete it, and the nice thing is like, oh, if they see something, they can biopsy the GI tract and see if that is like where we can get some answers. But I, I I'm just like amazed by how incredible of a workup you've done. And like this is someone who presented 7 times, and who was um, not taken as serious as they should. So I'm like really grateful that, I mean, no matter what else happens, I think the amount of thought and effort put into finding answers, it's what counts as well. So incredible job, friend. Ibrahim, any thoughts?
Honestly, I do have to say, the patient is really lucky to be under your care, Mark. Such a phenomenal presentation, and thank you for taking care so well of this patient. I guess I just had a question. So just because the fact that you guys are still entertaining a couple of diagnoses for this patient, would you mind like sharing with us if you've started any medications for this patient and if you've noticed any improvement in the last couple of days at least?
Yeah, and I think this will be very useful for Jeffrey too, if he's in the space or even just in the WhatsApp app after, because I think it was mentioned in the chat, most patients with seronegative spondyloarthropathies and like ankylosing spondylitis will respond to NSAIDs. And that's actually the first line therapy, even like over like prednisone. And this patient was actually on NSAIDs like IV ketorolac and then also naproxen, standing Tylenol, lidocaine patches, maxed out of gabapentin, 1,200 milligrams 3 times a day, maxed out on Flexeril, cyclobenzaprine, 10 milligrams 3 times a day, on IV Dilaudid, IV hydromorphone, and then oral oxycodone, and still having pain. So that is also, I think, an interesting thing to think about as well, of like how significant his pain was, and it just like not, yeah, responding to maybe the typical therapies for those conditions I mentioned. And the last thing I want to say, it was really hard to ignore the temporality of prostatitis and back pain. Like it was really like it's like it literally happened right after. And I thought of the exact things that you guys mentioned, like one reactive arthritis, but it's reactive arthritis is really uncommon without peripheral arthritis. It'll be really weird for a reactive arthritis to just present with axial back pain, spondyloarthritis, and then be so progressive. And then also, I think Charmaine, you mentioned this kind of like the Batson's venous plexus of how the prostate also connects to the spine, right? So that's why I was like, okay, maybe it's blasto prostatitis, then connecting to the spine, or kind of something like that. So that was just interesting that it literally happened right after the prostate.
Yeah, exactly. Like, are they related? Were they unmask like a spondyloarthropathy? Like, medicine is fascinating. And this is a really incredible case. Thank you again, Mark. Ibrahim, you're such a boss, even if you don't want to believe it. I really appreciate you. Thank you so much, Nikolai, for scribing. And Glenn, Mike, to you.
Okay. Thank you so much, Mark, for a brilliant his presentation and the discussions for today, Ibrahim, Shamin. So just to go through for my teaching today. Started off with an atypical presentation in a young patient to who presented with a progressive lower back pain, and also with pleuritic chest pain. So you mentioned that there could be unrelated symptoms and could should be treated differently, and also it could be an indolent pathway which is backed up by the weight loss also. So now dissecting the pleuritic chest pain, sort of the inflammatory causes like PE, other diagnosis that they can miss include aortic dissection, spondyloarthropathies. Also, the patient was also on antibiotics for prostatitis. So, one of the adverse effects of the antibiotics could be given, like Cipro, can cause aortic pathologies that can later cause pleuritic chest pain. Also, the fact that the pain was worse lying flat could suggest some autoimmune disease, and spine imaging can help with that. Um, the prostatitis infection, if it's due to the chlamydia, can lead to reactive arthritis, especially in patients with predisposed by HLA-B27. But actually, we just confirmed that with Mark mentioned that reactive arthritis in this patient would be usually it doesn't follow the ideal presentation for reactive arthritis. And then also we then talked about the diffuse ST elevations, and that because of the negative troponins and all that, it could just be pericarditis, which was then confirmed by the echocardiogram. And the differentials for that was granulomatous infections, autoimmune disease and infections. With the weight loss, this could be malignancy or a GI issue, malabsorption. We then saw the calcified granuloma, which could suggest TB, histoplasmosis. It is important to check the HIV status of the patient. Next likely causes for that would be SLE and lymphoma. We also talked about imaging of the kidneys, show some linear areas there. Could mean some pyelonephritis as a complication of prostatitis. And also we entertain some zoonotic infections, like hantavirus, leptosporitis, Coxiella as well. Also, plastomycosis was one of the differentials, and the labs for that came back negative, and it usually likes to cause prostatitis, and was one of the differentials. So at the moment, we don't have the final diagnosis, but the two top differentials are TB and IBD arthropathy. And with that, the ESR and CRP can still be normal. The patient is on NSAIDs and usually improve on NSAIDs. So that's all I had for the teaching. Thank you, Mark, for the presentation, and Sharmin and Ibrahim for the wonderful teaching that I got from you guys.
Thank you so much, Glenn, for that wonderful summary. Really appreciate you. All right, everyone. Have a great one. We'll see you later. Bye. Thanks, everyone.